m'étais pas dans l'hôpital défecté, j'aime dire qui j'ai des maladies qui me fait. Eh bien, celle ça a été fait pour moi, il était uniquement préparer tout testament. Je l'ai d'abord ici de l'hôpital Cange. Docteur Polo a dit non, je ne peux pas mourir.
I went to Haiti in 1983. I hadn't even started medical school. I met the people who would become my best friends and coworkers.
I had never seen such abject misery in my life.
We started going house to house, and the people were so sick.
And I thought, how can we get this fixed?
Jim and Paul were constantly going back and forth, and they would borrow things from some of the hospitals.
I would put that medicine in these big suitcases. They usually thought I was a tourist.
As soon as we opened the clinic doors, it was every possible disease you could imagine.
Elle a besoin d'urgence tout de suite. She's dying. I think it's too late. This was life or death. Getting medicines down there was life or death. And everything was conspiring against us.
The scientific community hated it. They said, it's not sustainable, it's silly, this could never be replicated.
We could not administer the program because we don't have the doctors.
In that script, we are uneducated, of course, stupid.
If you've traveled to rural Africa, you know this. People do not know what watches and clocks are.
None of our patients have died. One person died a few days after starting therapy because we started too late.
It took us from being outsiders right into the middle of the debate.
The results were dramatic and transformative.
We decided this could be something like a movement.
You are accountable to who? People are dying, my brother.
Rwanda is the most dramatic arc to a recovery.
Threats of the deadly Ebola virus landing in the East African region.
All borders are informed and screen anyone coming in Rwanda.
Tout le monde c'est monde. Si moi-même cap vivre jodi am aimé.
To me, this is about hope, and it's about rejecting despair and cynicism.
Good evening, or afternoon, or morning. I'm Tabitha Jackson, director of the Sundance Film Festival, and welcome to this conversation about global health as we find ourselves in the midst of COVID-19. We're also in the middle of a Zoom existence, so I know you will be forgiving of technical glitches, slight social awkwardness, and anything else that is a consequence of being in this online space, but it means that we can all be together, so that's the upside. My work in independent film has allowed me to witness firsthand the power of storytelling and the narratives that contribute to cultural and social change. So I feel deeply privileged to be part of this event. My more direct connection is that Bending the Arc, the film about the founders of Partners in Health and their commitment to community-based healthcare for all, that film was supported by Sundance Institute in its making. And it went on to premiere at the 2017 Sundance Film Festival to great acclaim, and it was an incredibly enjoyable experience having it there. Speaking of crowds, thanks to the documentary film lovers at Film Platform, who joined forces with ProQuest, your library database for research and discovery, we are gathered here today in the thousands. Apparently, you are joining us from 50 different countries, nearly 800 schools, totaling over 3,000 faculty, students, and librarians. So welcome, everybody. We've already received some great questions and have selected a few of those less bashful people to submit their questions via video. For those of you putting your questions into the Q&A box below, please include your first name, the name of your school or organization, and where you're from. And just so you're aware, this event will be, and indeed is being recorded. So now to the people you're really waiting for, you really want to hear from. First up, Dr. Paul Farmer is the Colocatrones University Professor and Chair of the Department of Global Health and Social Medicine at Harvard Medical School. Chief of the Division of Global Health Equity at Brigham and Women's Hospital in Boston, and co-founder and chief strategist of PIH, Partners in Health. Welcome, Dr. Farmer, you underachiever. Where in the world do we find you, and what has had your attention during this pandemic?
Well, I'm in Miami, Florida, at home. And, you know, I've been lucky enough to get to Rwanda recently for a while, and Haiti very briefly. But like other people listening, I've been focused on COVID, and I'm sure we'll get a chance to talk about it.
Absolutely. Welcome. Thank you so much for taking the time to do this. Ophelia Dahl co-founded Partners in Health, which began in Haiti's rural central plateau more than 30 years ago. She did it when she was a child, and now serves millions of patients in 11 countries around the world. Ophelia led Partners in Health as executive director for 16 years and now chairs its board of directors. Ophelia, where are you and what are you up to? What have you been thinking about?
Good evening, Tabitha. The question is, where am I emotionally? Where am I mentally? Where am I geographically? I'm geographically in Cambridge, Massachusetts with my family. And like I imagine so many people watching, at least in the US, focusing heavily on questions around this election and also thinking a lot about how to stay connected to all of these people that we felt so connected to in our work.
Thank you, and thank you for taking the time to do this with us too. Dr. Jim Yong Kim is Vice Chairman and Partner at Global Infrastructure Partners. Dr. Kim founded Partners in Health, where he developed treatment programs for multi-drug resistant TB and AIDS in countries including Haiti and Peru. From 2003 to 2005, Dr. Kim served as director of the World Health Organization's HIV/AIDS department. And from 2012 to 2019, Dr. Kim was president of the World Bank Group. Dr. Kim, where do we find you and what has your attention?
Thanks, Tabitha. It's great to be on. I'm based in New York City, well, just outside of the city in Westchester County. And my main job now is to try to build infrastructure in developing countries, things like transport and providing people with electricity and power. I'm doing that in the private sector now. And the reason is because there's just such a huge demand for the basic needs that all of us in the United States take for granted. There's such a huge need that we're doing our best to bring financing for that from outside sources. But I'm still very involved in COVID. You know, I have to say, I think with a lot of people in the infectious disease world in a state of almost mourning, given the response that we've seen, and altogether unnecessary carnage that we've just had to stand by and watch. And you know, normally we're outraged about developing countries and the inability of and the refusal really of the rich to provide the resources that are needed to fight these pandemics in developing countries. And now we're watching in the United States as you know, just so many opportunities were missed. And so I'm still involved in the Massachusetts response. I mean, Partners in Health is now running the contact tracing program in Massachusetts, and it's, you know, it's a crazy thing that we would have had to step in the United States to do a contact tracing program. But what happened, and you know, and Paul and I and Ophelia talked about this early on. We almost couldn't believe it. Why are they saying it's not possible to do the kind of testing, contact tracing, isolation, and quarantine that are absolutely necessary to bring the pandemic under control? I mean, Paul and I talked early on, and it was almost disbelief, given the work that the two of us did, you know, at the World Health Organization as infectious disease doctors, trying to convince them to have a larger aspirations for HIV in Africa, for example. We were in the position, and all three of us worked on this, of trying to convince Massachusetts or Ohio or some of the states we're working in convinced states in the United States to have higher aspirations in public health so that it could protect its people. It was stunning. It was, it's been a great experience in that I think we've made a large contribution, but the bottom line is we shouldn't have had to do this. The system should have been established and it should have kicked in automatically. And so I remain extremely involved with both Partners in Health and with infectious disease fights. And, I hope that things will get better. But right now is a very difficult time.
Thank you for that. And it leads us neatly, I think, into the meat of the conversation. And it is incredible being able to be here with you three and this audience at this moment. You are, as the young people would have it, legit in terms of being able to reflect on what we're going through now. And I, as part of the preparation, I wanted to just use a couple of clips in amongst the questions to get us going. So the first one I wanted to play. It's without any context, but actually, Dr. Kim, you've just laid the perfect context for it. So, it is around the work, and more specifically, the response to the work that you were doing around multi-drug resistant TB. But that's all I'll say. So, Ali, can you play the clip?
And then we presented the results. And the results really, I think, were shocking to people.
I looked at your data and was quite struck by the suggestion that there was over 50% cure rate, that I just have a hard time accepting that those numbers will float unchallenged.
It's an impossible.
The vast majority of the TB community literally lost their minds.
Look at the results we just heard. 70% of the cases are cured. My belief is that those 70% never had multiple drug-resistant TB. They were folks that took some of the pills that were in the blister pack, some were pounds, some were sold. If you've ever been in any of these countries, you realize that their ability to screw up the program stems all the way from the top, all the way down to the bottom.
The old school TB crowd was furious.
How important is it to treat multiple drug-resistant TB? I don't think it's very important at all. I don't think it has very much of an impact.
Even if we believe it, you can't do it.
Maybe it's a good idea, but where and when and for how long? We need to think about sustainability.
I've never seen this debate play itself out among patients saying, I don't really think I'm sustainable.
The only time that I hear talk among people like us, academics, or shrinking resources, is when we talk about things that have to do with poor people.
The main resistance always is cost. These patients, Black people, brown people, poor people, just don't matter.
We feel that what could come out of this meeting is that the data that we showed you of our success in treating MDR-TB could lead to a vision of expanding resources that could be very powerful.
So one of the reasons why I think film is so powerful is that it can draw us in through the portal of individual experience and empathy and story in order to reveal a more kind of visceral understanding of, in this case, systemic structural inequity and its underlying assumptions. And for me, that's what's revealed in this clip. You'd done the science and published the results, but the barriers to progress were resting on something else, a kind of arrogance. And so I wonder whether you are feeling any resonances in the context of this pandemic, given what you said about us, all four of us happen to be in the US at the moment and feeling the situation here. What are you seeing, Dr. Kim? Maybe just continue the thought you were having.
Well, at the time around MDR-TB, what the so-called experts were saying is there's just a limited amount of money. There's not going to be enough money to treat MDR-TB along with regular TB. And, resources are limited and there's not enough money. And, it's not possible. This was the kind of language that we heard. Look at the situation now. And the thing that's been driving me crazy is we did a $3 trillion stimulus. And then now we're talking about another $2.5 trillion stimulus. And there's been almost nothing for public health. And so we spoke with Speaker Pelosi, and many of the people who are on the select committee, Andy Kim, no relation, but a very good man who's trying to help get some money for testing, contact tracing, and what we call supported isolation. In other words, when people need to isolate or quarantine to protect themselves and others, many people especially people who have low resources, they need support. They need food support. They need diapers. They need all kinds of things to be able to keep themselves healthy. And so we convinced them to put $75 billion into the next stimulus bill, and that has been stopped. And the specific point of contention coming from the Republican side is we don't want any money for the public health response. So back then the argument was there's not enough money. Well, what we know is that if you need it, you can raise $3 trillion very quickly. And the interest rates are so, and just put on my sort of finance economics hat for a second, interest rates are so low now, people are saying, no problem, 3 trillion, we can handle that. What's the interest on 3 trillion? Not much given the interest rate these days. And so it was never the case that there wasn't enough money. And so what we've learned is that even when we're willing to spend trillions of dollars on economic stimulus, when in fact the problem is a public health problem, we're still not willing to spend anything in trying to tackle the public health problem. So this is it's almost like a shared madness that has overtaken this particular country. How can you continue to put money into economic stimulus when the core of the problem is a public health issue? Now, what they'll say is, oh, we're just going to wait for the vaccine and we're going to wait for therapeutics. Well, Tony Fauci's been saying if we get a 70% effective vaccine, we will be very, very happy. So let's say we get a 70% vaccine, and let's say that if we're extremely optimistic, 50% of Americans get the vaccine, because the numbers we're seeing about the number of Americans who will get a vaccine are very low, maybe less than 50%. That's 35% of the people then who will be covered. And we're not even sure that we're going to get a 70% effective vaccine. And so even if there is a vaccine, it will not stop the need. It will not get rid of the need for the full public health response. So we've been saying it and saying it and saying it. But on the one hand, there's a collective madness about not putting more money into the public health response. And then there's also, a collective magical thinking that treatments and vaccines will solve the problem when we know that it won't. When people ask me, won't treatment and vaccines solve the problem? I say, yes, in China, in Taiwan, in South Korea, anywhere where they have an actual public health response fully in place, the vaccine and new therapeutics will solve the problem, but not in the countries where it's out of control. So, I don't know what it is, Tabitha. I don't know what the collective madness is, but when we were trying to treat MDR-TB among poor people, it was there's not enough money. And now when, we're over 50,000 cases a day again, the collective madness is of two types. We're going to put fiscal stimulus out there, but we're not going to try to get at the core of the problem. And by the way, treatment and vaccines will solve the problem. And so, Tabitha, I'm terribly worried. And the exact same thing, and I would say it's even worse than when we were trying to fight MDR-TB and HIV, because the impact of the American economy on the global economy, the prospects for poor people anywhere in the world are enormous. So, it's not just bad for working people in the United States or just bad for the US economy. It's bad for the entire world because so much of the global economy rests on the success of the US economy.
Yes. Thank you so much for that. It's such a full answer. It also leads us neatly into a question from, and Ophelia, I'm going to address this one to you. This is a question from Daniel, who's a faculty member at Siena College. And Daniel asks, what role can non-clinicians play in the effort to improve health globally?
Oh, well, thank you for that question, Daniel. You know, it was actually Jim and Paul some years ago when I thought I really did respond to what I had seen as a young person in Haiti and think that this was a health problem. So the only way to respond would be to go to medical school or to become a clinician. And it was my two good friends here that actually said there are many other ways to respond to this. And I'm grateful to them for doing so, because as we can see, I mean, I like to think I've been involved in global health as a non-clinician for many years. And I would add quickly that almost all of the people that we work with in our different, you know, whatever line you take, would be non-clinicians. That might not be true for, you know, for Paul as a professor at Harvard Medical School, but, you know, Jim is an economist, and certainly our 17,000 strong members of our organization are spread about the world, and very few of them are actually clinicians and medics and that sort of thing. I mean, it's perhaps an obvious point, but you need every single profession to be part of this. You need architects, and you need economists, and you need hospitality people. And I think that what I failed to see early on was that great systems that need to be built, webs of connections, need all kinds of different professions to do it. And I think that there was a sort of a single-mindedness that I had, a rather narrow thinking that the only way to respond to the problems of a giant health crisis is with clinicians. And, you know, it's one of the reasons that we built with the government of Rwanda, a university of global health equity, really not a medical school, not a nursing school. And it was so that we could really respond with all different professions and all different kinds of skills, including, because I know that Daniel's a professor himself, educators right up there in terms of being part of this. You know, I would say that you do, if you're lucky and can do what you're good at, and that you bend that towards justice.
That's a wonderful response, and I'm barreling forward because there are so many great questions, and so I think let's take a video question, and this is from one of the Partners in Health Engage chapters. So let's have a look at that, if we may.
Hi, so I'm a senior at The Ohio State University in Columbus, Ohio, and my team has a question for Dr. Farmer. So throughout time, Partners in Health has had a lot of success in implementing new public health interventions across the world, but what are some factors that you found to be crucial in continuing this success during the pandemic?
Dr. Farmer, you're on mute.
Sorry about that. Thank you so much for the question. You know, one of the things is that if you look at the 17,000 people, Partners in Health owes a lot of its success to building local capacity and learning from local capacity, frankly. So when I was recently in Rwanda for a month, you know, our travel was curtailed. Wasn't able to go on campus of the university because of lockdown for the students. I was able to go to the hospital, and one of the things that really pleased me to one of the hospitals was that you know, I wanted to see how the critically ill were failing, those without COVID, because there's very little COVID in Rwanda. People with cancer particularly, because we have a large cancer treatment program in northern Rwanda. And because they're all locals, you know, the people running the program, the clinicians, you know, and there are plenty of doctors and nurses, but also the managers, the community health workers, supply chain specialists, the drivers, they're all from Rwanda. And so what they did was, as the ability to move around, you know, was decreased because of shutdowns, they reassigned more vehicles to going to find the patients who were unable to meet their keep their appointments. And some of them were in other countries, Burundi, the DRC, Uganda, Tanzania. And they told me that they really hadn't lost any patients to follow up. And if you take a sort of missionary approach to global health, which I'm not, disparaging. I'm just saying, if the missionaries are people who are going to go in and leave, again, using the term not in reference to religious people, but people who have short-term stays, then you're going to have all kinds of interruption of services. These are local people, whether they're in Haiti, Rwanda, Malawi, Lesotho, Russia. And I think that's a big part of it. The other part that I want to mention before I leave is, you stick at something for 35 years and you work in a let's say in one place over time, then you're going to see a lot of improvement. So part of it is just sticking with it. We haven't let go of any of the other work we're doing to focus on COVID. We're still doing all that work because we work with a great group of people who live and serve in their own countries.
That's wonderful. And you said you wanted to just say that before you leave. Don't go anywhere because we haven't finished the session yet. So stay right where you are. Okay, so there's a question I'm going to take a minute on this one with all of you to answer this question, because it's a fascinating one. And it is from Christopher, a graduate student in public health at George Washington University. And Christopher says, from my perspective, Partners in Health and the three of you have had many successes. What are some of the failures and the most important lesson learned from those? So I'm going to ask each of you, I think, to just pick one of your signature failures and the lesson that came from it. And perhaps I'll start with Ophelia, if I may.
What, just one? Just one. I can't do that. I mean, the one that comes to mind immediately, there are some sort of interesting ones from way back. And if you would permit me to mention two quickly, I would say our failure, and I bet you Jim and Paul are thinking about this too, our failure to work with the public sector quick enough. Way back, we were probably working for 10 years altogether before we sort of had a revelation with our colleagues that we needed to not build a parallel health system, but really work with partners like the government. I mean, and partly that was because we were in a place like Haiti where it was under a dictatorship when we started working there. We wanted to be under the radar. We wanted to build something, but that was not true later. And I think it's one of the signature things that we do, and it's a very difficult thing in some places to do, but it is the thing. If you believe that healthcare is indeed a human right, it's a thing that certainly only governments can confer upon a population. And then one other quick thing is just, and when I think about the CEO now of Partners in Health, Dr. Sheila Davis, who's a nurse and an educator, I think that we took a little too much time to really bring in. She was our first chief nursing officer, and it took us a long time to bring in our first chief nursing officer. So I would throw that in there.
Fantastic. Who would like to go next with your juicy failures?
Well, go ahead.
Great.
Well, I thank you, Jim. I was just thinking, and this is crowding my thoughts about people that we've lost, patients who should not have died. There are fewer of them now, but each of those feels like a failure to me. When you started that first clip, I was overwhelmed because I'm that man has become a good friend of mine. The person who, with a deep voice and the kind of cool Fu Manchu 15 years later. But I mean, you can imagine how close to death he was, right? And now he's a good friend of ours. And I mean, he's still alive and well 20 years later, or 3 years later. He had AIDS and tuberculosis, as is explained in the film. But you see how close he was to death, and you can imagine in those years, the 80s, the 90s, we met a lot of people close to death, and they went on and died. So those are the big inner rebukes going on in my mind, is remembering some of those folks. And anytime we delayed action, on the same grounds that we're criticizing in others, that's a failure.
Mm-hmm.
You know, Tabitha, and Christopher, it's a great question, because part of some of the founding principles of Partners in Health were that we were not going to fall into the trap of describing our work with success narratives. You know, what we said was, you know, if we truly stand with the poor, we're going to lose so much more often than we're going to win. And, you know, you'll never forget that, you know, the three of us, sometimes it was only the three of us sitting in a room and looking at just the carnage that was around us, trying to just find enough money to you know, keep the clinic going in Haiti. And we had to shore ourselves up by saying, hey, it's never been about success narratives. It's never been about our heroism. It's never been about, you know, winning. It's always been about standing with the poorest. And then just some crazy things started to happen. I mean, I think we took on really major fights. We took on fights like, okay, so, you know, what we learned was that if we're going to treat multi-drug resistant tuberculosis in the slum in the northern cone of Peru, we had to take the fight to Geneva, to WHO. And so we didn't do this because we thought that we could then engage in victory narratives. We did it because our partner, Jaime Bayona, and others said, if you don't change what's happening in Geneva, you can't change what's happening here. So, you know, a lot of people think of Partners in Health as, oh, they're so successful, you know, they're doing such great things, and, you know, the things that they do turn out to be so successful. Let me tell you, to this day, right, even though we are, I think, running the best contact tracing program in a state in the United States, I can list for you, and Ophelia has a longer list of all the places that we would have liked to intervene and help them move more aggressively on doing contact tracing, so that we could protect the overwhelmingly African American, Latino, you know, Native American, the overwhelmingly people of color focused death rates. I mean, this is, if we could have, we feel so badly that we hadn't done more. And there's a Secretary of Health in the United States, in a large state, who was one of our students, who we talked with early on, and we told him, you have got to move on this quickly. And though he wanted to, it just wasn't possible. And so to this day, it's failures. And so here's what I would say. If you're going to truly stand with the poor, if you're truly going to stand with those who have these overwhelming, you know, predisposing conditions that are leading to such terrible outcomes, right? If you're going to stand with those people, most of the time, the most important thing for you is to admit that you failed. And then what makes you continue is not because you win, but it's because you have faith, you're committed, and you persist, because you're doing it on the basis of principles. So, you know, no matter how well known or celebrated anyone might be, if you're going to do this work, you have to continue to renew your commitment to stand with the poor.
And Christopher, thank you for your question too, because it's when we think of film and what film can do in helping, you know, the average viewer to understand really important but complicated subjects, I think Bending the Arc is a great example of this. It wouldn't have worked if, in Dr. Kim's words, it was just a victory narrative, a kind of frictionless, here's what we did, it worked, it's very successful. It doesn't make for a narrative that people can engage with and really understand what it took to achieve that. And it's a very kind of Western storytelling, 3-act structure. There has to be something that your protagonist wants that they can't have, and that there's a conflict and then they get it. I don't mean it to be as literal as that, but it has been the case when independent filmmakers working with social entrepreneurs trying to make moving image work and media and film that can galvanize a broader audience, often either the filmmakers or the organization do not want to reveal the difficulties and the messiness and the complexity of the situation, but that is where the heart of the story and the heart of the learnings often are. So, so I appreciated that question too. So Ali, why don't we have another video question? Because I can see there are some great questions also in the Q&A box. So let's do a video question and then we'll take it from there.
Hi, my name is Franklin Leong, and I'm a graduate student at the Johns Hopkins School of Nursing. This question is for Dr. Jim Yong Kim. What do you believe are the main obstacles in promoting health equity around the world in the next decade? Thank you.
Well, you know, the conversation, I think, is changing in a very interesting way. You know, we've been a part, you know, Paul and I specifically, we've been a part of expert panels that have said, you know, there could be a virus that could shut down the global economy. The last one that I was involved in was in October of 2018, right before I left the World Bank Group, in which we put out a report that essentially said, this could happen, and here's what the impact it could have on the global economy. And of course, nothing was done about it. And in fact, you know, in the United States, not only did we not prepare, we sort of disprepared. You know, systems that were in place, we dismantled in terms of preparing for an outbreak like that. And so I think right now, there's a completely different conversation going on. And I think there's the sense that healthcare and having the capability, for example, of making vaccines very, very quickly, having the capability of having, you know, testing, contact tracing, isolation, and quarantine in most of the rest of the world outside of the United States, there's now a profound sense of how important that is. And I would say, especially, and there are some places where that understanding is brand new. Europe, for example, Europe hasn't had this kind of outbreak in a very long time. And my understanding is that their own sense of how important these things are has grown tremendously. And so I think there's an opportunity. And the opportunity is that we now have to take this moment and say, okay, so you know, what we need to do is frankly what Partners in Health has been saying all along. You have to build functioning health systems that are capable of not only providing the basic care and even you know, what has been thought of as very complicated care, surgical care, cancer care. You not only have to do that, but then you have to also build systems that are capable of responding to pandemics, that are capable of scaling up testing quickly, of doing contact tracing, you know, of isolation and quarantine. And you know, guess what? The places where we work, their capacity for doing that work is so much higher than in the places where, frankly, we haven't done that work. And so I think the formula is fairly straightforward now. You've got to, you know, the idea of universal health coverage is important, but it's got to go further. You know, there has to be access to services for everybody, and that those services have to be linked to robust public health capabilities. You know, it's hard to imagine that after this experience, we will forget it, just forget about it and go on with our business and not invest. But you know, one of the things that has been oft repeated that I think I was the first to say is that, you know, the history of infectious diseases has been cycles of panic and neglect. And so we're sort of in panic, but because the panic has gone on for so long, my hope is that something fundamental has changed. You know, in all the countries where the response was robust and effective, it's because they had experience with the epidemics and pandemics in the past. Korea had an outbreak of MERS, and they completely changed their laws so that they could be better prepared for the next pandemic. You know, many African countries that everyone thought, oh, the African countries will be devastated, because they had experience with Ebola, they've done pretty darn well. And so, you know, now that so many people in the world have had this experience, my hope is that we won't go back into neglect, but we'll ask much more, I think, informed questions. What will it take to build systems that will work not only in providing care, but in responding to pandemics? And I can tell you that at Partners in Health, we know exactly what those systems should look like and have participated in building them in many places in the world.
So I'm going to jump on that thought, Dr. Kim, and I'm just seeing a question from John, who's a student at Portland Community College, who along those lines says, do you think good things might emerge from the pandemic? Forces for reform of the medical community and healthcare in America and abroad, perhaps the destigmatization of mental health, which has become a silent secondary pandemic due to the stress of this year, or are the static holding pattern forces too strong? Dr. Farmer, will you take that one?
Well, sure. Beyond that, beyond medical reform, which is critically important. For example, what does it mean that you don't have contact tracing? What is vestigial or neglected? And that's the public health apparatus, which, as we pointed out, also has tended to have low expectations. But beyond anything in the public health and medical arena, I think, I know, speaking on behalf of Jim and Ophelia, I know we're hoping for major changes around everything from unemployment insurance to, as Jim said, universal health care is still important. It requires more. But we're hoping that there'll be a new and deeper and more committed conversation here. I'm speaking of the United States right now. And, I would even say that, as many have, when you think about the murder of George Floyd, would that sustained response, not sustained long enough yet, but would the sustained response to anti-Black discrimination have occurred if it weren't for COVID-19? And, I think it's, people were cooped up watching their televisions. I mean, I've watched more television in the last several months than I have in the decade preceding it. And, so I think our aspirations, to John's question, are much higher than ever, because a lot of these social pathologies have been revealed as a viral pathogen spreads through our ranks.
I heard someone refer to COVID-19 as COVID-16-19 the other day, which was striking. Everything is connected, and I hesitate to reveal the depths of my ignorance, but the way that it's often talked about is that these segments of society are more susceptible to the most kind of vicious or fatal effects of COVID-19. African Americans, Native Americans, as you mentioned, as though it were a genetic predisposition rather than an effect of poverty. And I may be wrong, but do I, as a well-off, comfortable, but woman of Nigerian descent, am I more susceptible, or is it nothing to do with my genetics? In that sense, it's to do with.
There's no good evidence yet that it's due to any genetic or biological factor. None. Right. Maybe there will be. There's certainly a lot of hypotheses and speculation, but right now, the question we should be asking is, how does this virus become embodied in people of color who are essential workers, who often don't have things like unemployment insurance or a means of isolating in place? So I would say, no, you do not have some untrammeled and exaggerated risk, that other factors, protect you. But these debates have gone on for centuries now, right? The hereditary weakness or hereditary fitness that was alleged to cause all kinds of disproportionate problems among African Americans in the United States. This goes back for, probably to 1619. So I would say no, that these are social pathogens that are colliding with a viral pathogen.
And I think that we, as storytellers, filmmakers, in the media, we can perhaps do a better job of pointing that out whenever we use the shorthand of who is most susceptible, because the reason is key to figuring out how we, I don't know, I'm telling you, giving you advice on how to fix this. So there's a question here from, and forgive my pronunciation, it could be Trudy Jacobson or it could be Trudy Jacobson from Northern Illinois University, George Washington University. And Trudy says, what is the best way to shift responsibility for health infrastructure from NGOs, IOs to government? Ophelia, can you take that one?
You know, actually going to tough that to the ex-president of the World Bank, because I know he's got a good answer there, and I will bolster it.
You're muted, Jim.
Well, you know, there's a general answer, but there's no simple answer to that. In fact, and you know, I think Ophelia said it very well. We learned a really important lesson but the lesson we learned was I don't blame us too much for having avoided working with governments for a while, because the governments that was in place in Haiti was related to the Duvaliers. How are you going to work, you know, with the Duvaliers and the Tonton Macus? I think it's difficult to see how you do that. But then I think the lesson came from going to other places where governments were really effective, or governments desperately needed us to work with them, and that it ended up working out, you know, much more effectively. And I would say that in Haiti now, even though it's still possible that they may elect really bad leaders, you know, we're so deeply embedded in the healthcare matrix that I think that the work with governments will outlast any elected official, which is what I think is great. But now, you know, there are other countries. You know, Bangladesh, for one, had a lot of really, really great NGOs. You know, BRAC has been an incredibly effective NGO, and part of it was that in Bangladesh, and to begin with, there was just not enough infrastructure to provide all the services. But you know, the task of getting governments to take responsibility for the health of their people is not so straightforward. And so one of the things I recognized when I was at the World Bank Group is that leaders got away with paying lip service to being committed to the health of their people, and then put almost no money into it. And so Tabitha goes right back to Nigeria, because Nigeria was my sort of whipping boy for quite some time. And I said, you know, every time I hear these leaders stand up, they say, we're so committed to health, we're so committed to education. And then if you look at their actual budgets, Nigeria was spending 0.7% of GDP on healthcare. And almost all of that was loans that the World Bank was providing them. So they were not putting oil money into healthcare. They weren't putting any money into it. And so what we did at the World Bank was we said every year, and now it's going to be every 2 years, we're going to rank the countries. We're going to take four very straightforward health indicators: childhood stunting, under 5 mortality, adult mortality, and life expectancy, and then add to that what we call the learning adjusted years of education. In other words, you know, not just how many years were you in school, but based on all the testing results that we had collected at the World Bank, how much education did you really get? And so unfortunately, in Malawi, 11 years of education was the equivalent of about 5 years of education in Singapore. And so you put all that together, you can actually rank the countries from 1 to 157 was the first ranking. And the reason we did that is because we wanted to hold leaders accountable. And when one of the things I've learned is that the only time that government officials often pay attention is when they're compared to their neighbors. And so what had happened, and this is the most interesting response, was in Nigeria, because I kept talking about Nigeria. I kept saying, how can you say you're committed to health when you spend 0.7%? Yes, there should be more money from the outside. We agree with that completely. But what often was happening was they would take that money from the outside and then reduce their own expenditures on healthcare. And so if we had a ranking system, we wanted to, put their feet to the fire and hold them accountable. So I'd say, it's not a simple formula. Oh, healthcare has to go to the government. Well, healthcare can go to the government, but if no one's holding them accountable, they may get away with spending almost nothing on healthcare and yet going to meeting after meeting. They would come to the World Bank and wax poetic about how committed they were to healthcare. And I knew what their budgets were. And I would say, oh, really? But then why are you only spending this? And so, I don't think there's any magic formula to say NGOs shouldn't do it, government should do it. The test is how much, to what extent are systems actually in place that provide poor people with a full gamut of healthcare and at the same time is capable of responding to public health issues like pandemics. Does that exist or does it not exist? And luckily, at the World Bank Group, they have continued to modify and enhance this rating that's giving a very good sense of how they're doing, not in terms of expenditure, not in terms of percentages of the budget, but what's actually happening with children, what's actually happening in the educational system. I think that's the most important thing to do. It's not, yes, we should raise more money out there in the world, right? That's really, really important. But we also need to hold the governments accountable, and we need to hold NGOs accountable too, frankly.
That's where I'd like to jump in to bolster is holding the NGOs accountable, because I do think that there's our experience certainly suggests that there are thousands upon thousands upon thousands, I think maybe even 11,000 NGOs that are working in Haiti alone. At least, we knew that figure a few years ago. That unregulated, extremely, almost all of them, well-meaning, thoughtful, committed groups of people, but unregulated and untethered to each other, untethered to the government in any way. And when we talk about working with the government, we, so often we are asked the question, which you haven't asked and no one has asked, about sort of how you do work with a government that is supposedly corrupt or difficult to work with. And I think that we have really found, most of all, that governments are not monoliths. We have found people who are deeply engaged as civil servants at the local and the national level, and there are ways to build relationships within these different groups. But so I, of course, agree with Jim and knew he would give a good and complex and meaty answer. But I would also say that there is this other piece of it, which is NGOs do have to, at least agree, even though it is complicated to work, even in part with governments. That's the way things are going to change systemically for a long time. And it's a more difficult thing to do. And NGOs, particularly US-based NGOs, are not used to having to do that kind of work, because it's complex and rewarding.
So sticking with the systemic somewhat, I think this question, I'm really fascinated as to what your answer will be. We in, adjacent to journalism, certainly in nonfiction filmmaking, know that we are swimming in this age of misinformation and disinformation. And it's particularly legible when dealing with something like a global health pandemic. So this is a question from Nicolette, who is a graduate student of public health at Eastern Washington University. Nicolette asks, as public health officials, how can we help fight false information that travels within our communities? How do we build trust in this fear-based era? Because this is kind of a matter of life and death, getting this right. Dr. Farmer, can I come to you?
Well, I'll give it a try. I mean, I think it's hard for public health officials. In some ways, it's probably harder than for clinicians, because, just going back to the Ebola epidemic in West Africa that began probably in December of 2013, we worked largely, Jim worked in all the places because he was president of the World Bank, but we worked largely in Sierra Leone and Liberia. And these are two countries that have recently gone through civil war. And, trust is at an all-time low. They're also poor investors in healthcare, not, maybe not in terms of the fraction of GDP invested, maybe not as low as Nigeria, but, not very good compared, let's say, to Rwanda, where 20% of the public budget goes into healthcare. So how do you build trust in the middle of a crisis? And I think for the public health officials and for the clinicians, the best answer to that was to serve the sick, to take care of people. And the more visibly you were doing that in a community, often the communities from which these folks were from, our new colleagues, visibly working on behalf of the sick, and they were mostly people living in poverty before they were sick, is an important way of building trust. We just did not have the kind of security issues in either Liberia or Sierra Leone that many other groups did have. And, we weren't focused on safe burial of the dead. There was an average of 10 attacks per month on the Ghanaian Red Cross in that first year of the epidemic. We didn't have that, but we were very visibly invested in scores of communities, and our numbers at Partners in Health, people working for Partners in Health, rose into the hundreds and then over 1,000 in the course of the first few months. We also hired a number of Ebola survivors, probably even most of the Ebola survivors we met in Sierra Leone. We invited them to join our team when they were feeling better, and they're still part of our team. I think the way you work is part of the answer, the way you work in a community, especially one that's been riven by a lack of trust. I mean, you can imagine, and I'll stop here, that in Haiti, after 37 years in the same communities, we're, well-known quantities. And again, our Haitian sister organization is run by Haitians and has been. And they're well-known quantities, across, not just across the parts of Haiti where we work, but in the capital city as well, in the Ministry of Health. So anyway, that's a longish answer to a great question, but part of it is humble service to the sick.
Can I jump in, Tabitha, for a second?
Yeah, please. Yeah.
So I think Paul is absolutely right, and that's the that's the path we've always taken. But I think around COVID, I think the public health community has to do some reflection and some soul searching, because the arguments that we had amongst ourselves in the public health community have filtered out into the world in a way that I think has had terrible consequences. For example, in the White House right now, the notion of waiting for herd immunity has become very popular. Now, we were having arguments early on about, well, should we really be aggressively testing, contact tracing, isolating, as we have in every single successful public health response in history? Should we do that, or should we just wait for herd immunity? Right now, I don't think any of those who were talking about herd immunity, because it was part of their research and they were excited about the idea, I don't think they would have said it's okay for 200,000 Americans to die. I don't think that they would say, it's okay for us to do nothing. It's okay for us to not have enough testing. I don't think they would say that. But that kernel of thought that, well, maybe we can just wait for herd immunity, spread like wildfire. So what do President Bolsonaro in Brazil is just saying exactly that. We'll get to herd immunity. And now, you're hearing it coming from the White House as well. And so what I've always said is, wait a minute, if you are going to wait for herd immunity, that's not what you're going to get. You're going to get herd culling. And we know exactly who's going to get culled. This is not an egalitarian virus that is affecting everyone equally. If you have 5 homes and 5 bedrooms in each home and have servants and people who can drop things off, you can protect yourself. I mean, there are ways of protecting yourself. But if you are in a quote unquote essential worker, but are thought of as expendable, which is what many essential workers have been saying in their own critiques of being forced to work in dangerous settings, you can't sit around and scratch your head and say, gee, I wonder what herd immunity would look like, because those are the people who are going to be at highest risk. And so I think, once again, we failed to communicate effectively with the general population. And so here's another thing that just happened right away. Again, early on, when there were like 0 cases in Florida, when there were 0 cases in many states, public health officers in certain parts of the United States said, there's community spread now, it's too late for contact tracing. And then that just couldn't have been more wrong, right? And as the pandemic started getting worse, what you heard Tony Fauci talking about was we've got to have social distancing. We've got to be much more serious about locking things down. I actually called Tony and I said, Tony, but shouldn't we also be doing testing, contact tracing, and isolation and quarantine? He said, of course we should. Of course we should. But I'm just trying to convince powerful people that we have to even do social distancing, right? And so there was a disconnect, but the reason for it, I think, are complex. But when the most powerful country in the world, backs away from the most important health institution in the world, World Health Organization, that's really damaging.
Mm-hmm.
In all of the successful efforts of controlling pandemics, then it goes right back to smallpox. During smallpox, there were 300 CDC employees that were seconded or were working at WHO as WHO officials, but were actually paid for by the CDC. So the connection between the US CDC and WHO has been among the most important relationships ever in terms of controlling public health. That relationship, was broken apart. So it's not all the public health officials' fault, but I have to tell you, we were not thoughtful, careful, and strategic in how we were communicating about what needed to be done. Mm-hmm. And it got to the point, I was told, I was on a show and I was saying, we just need to get contact tracing. And somebody who's completely not a public health official just blurted out, but it's too late to do contact tracing, right? And so I stopped them and I said, what are you talking about? Right? Well, this community says it's too late to do contact tracing. I said, you're never going to get this under control. And even if you can't chase down every contact, you have to put the system in place now so that when the cases do come down, you're going to be in a situation where you can chase down every outbreak. And frankly, it's just happened in very few states. Luckily, Massachusetts is one of them.
Thank you for that. I'm going to take us now back into the film, into the world of the film. And Ali, if you could play my second clip, because I think it leads us nicely into our final question. And so let's roll that clip.
Our patients went through hell in getting treated.
Melquiades, más que el tema de tomar los medicamentos, sí, es un problema de desesperanza, ¿no? De agotamiento, y es entendible, ¿no? Pasa.
These community health workers were very, very courageous and special people to be supremely compassionate with these patients who very well can infect them. Both community health workers and patients, they didn't just do this for Carvalho, they did this for the whole world.
Sin guerra no lo puedes ganar. Tiene que ser un buen guerrero. Yo voy a ganar.
If the first patients got cured, then we knew that we had an argument, because the first stage in the argument was, even if you wanted to do it, you shouldn't start because it's simply impossible in resource-poor settings.
Fue una lucha en la que fue bien dura. Gracias al apoyo tanto de los doctores, tanto de familia, tanto de personas que realmente estuvieron ahí, se puede decir que estoy aquí.
We almost let him die. To think
we almost let him die just because we thought it was inconvenient for us, just because we didn't think that he deserved it. I've seen others like this, but it's just, this is what a transformation, my God. I mean, look at the confident young man, you know, who's out to take on the world.
So the question that clip nicely leads into, I think, is from Carl, who is an anthropology student at Southern Utah University, Utah. How did you keep your focus on the strategic mission of Partners in Health, i.e. rebuilding health systems, while surrounded by such suffering that would seem to require immediate tactical disease or illness intervention for each individual right in front of you? I'm aware that this is the kind of concluding moment, so feel free to answer Carl directly or just leave us with a thought that comes from that clip or Carl's question. Dr. Farmer, let's start with you if we may. And you're just on mute.
I think, Carl, that it's not a choice that we should be making. It's kind of like, you know, hearing people say, well, it's too late for contact tracing. I mean, how do we know that? You know, one of the things about being in a clinical space, and I was largely the clinician in many of these efforts, meaning I focused on at the behest of my colleagues, including Jim and Ophelia, I focused on the needs of the critically ill right in front of us. And so we had a division of labor, right? We had a division of labor. We considered policy issues. We considered, you know, what might promote more quickly serious investment in health system strengthening, to use your term, Carl, and the one that we use. But we never turned our back on those who were already critically ill or injured. And, you know, if I had to point to one other thing that I think makes a difference, it's, you know, you can't build trust if you're turning your back on those who are critically ill or injured, but you can speed up the rate at which trust is built when you attend to the immediate needs of those in front of you. So I do not think of those as, you know, opposed tasks and one less strategic than the other.
Ophelia?
Yeah, I mean, the question is such a good one and a juicy one too. I am reminded at once of in some ways I feel as though the arguments have often, and I know that this is not what Carl is doing, but the arguments have often been to sort of pit services against each other. The idea that we can do one thing, but we can't do the other. And the most fantastic learning that I have had in my years of doing this is really the idea that we often make things complex to justify not addressing them. The things that seem complex, you know, in any system, really are not very complex. So I would say personally, I felt pretty overwhelmed as a young person, someone under 20, when I saw the suffering in front of me. And I also, with the help of friends and colleagues, also had been socialized in such a way to realize that you don't have to do one thing or another. You really can address the web of complexity in front of you by doing things one piece at a time and really taking it on. I think that, you know, I'm reminded of the arguments around prevention or treatment, for example. And, you know, I think this is something that we have to sort of, you know, I think it was perhaps, and because, is this the wrap-up question, Tabitha?
Yes, yeah.
Yeah, you said that because I think that it brings us also nicely to this idea that, you know, we've been able to do this, we've been able to use our lives in this way to be able to address this kind of thing, to be able to see and work with people who are proximate to patients, who are proximate to problems, and be able to use our own privilege and muscle and experience to be able to take on things like systems, policy. Look at where, you know, Jim has decided to use his own muscle and all of us together, and now with 17,000 colleagues or even more, I would say the other thing too is, and I really do want to get this in here, is that the complexity piece is also linked to the idea that the two fellows I'm with are also academics. They're also scholars. And Paul, and it's the only one who hasn't published a book yet, but Paul has a book coming out on November 22nd, actually, which really does help us to do this. It's called Fevers, Feuds, and Diamonds. And it was, I think that understanding history and understanding everything that goes into this is something that we've all tried to apply to the work that we do. And that really has, being able to understand this, to study it, to reflect on it, to have the muscle and the privilege to be able to address it. I mean, I can't imagine being able to be any luckier than spend my life that way.
Ophelia, thank you. And if I can come to you, Dr. Kim, for some sadly brief, a brief closing thought, if I may.
Sorry, Jim.
As the designated crier in the movie and in the family, I would just say, what's happened over the years is that Partners in Health people have developed some instincts. I don't know a lot of the 17,000 people. I used to know everybody almost that worked in Partners in Health, and I don't know them now. But in getting back involved with Partners in Health, I've met many of them. And what I've found is that the instinct is there. The instinct that I think, and especially it's been Ophelia as the leader of the organization per se for so long. The instinct that's been instilled is that you don't start with a preferential option for your own brilliance. You don't start with a preferential option for your own efficacy. You don't start with a preferential option for your own idea. You start with a preferential option for the poor. And that means to face their suffering directly. And so I'm now meeting, and I'm working with Partners in Health. I couldn't be on the board during the time I was at the World Bank, but I've since rejoined. And I'm meeting people from so many different fields. And this is also addressing some of the questions that I looked at in the Q&A. What can I do? What can I do next? How can I help? Well, I think if you wanted to work with Partners in Health, you have to have some very fundamental convictions. And that is that I will not avert my gaze. I will not avert my gaze from the suffering of the poor. I will not get caught up in victory narratives, especially about myself. I'll try to start with the suffering of the poor and then move from there in the directions that are required if we're going to make a change. There's a whole group of Partners now that does nothing but work with Congress to try to change laws so that the poor can be better affected. I don't think when we started, we couldn't have imagined that we'd have a whole team that would be working on that, and they're very good. So that's, I think, the core of the film. That's the core of Partners in Health. And I think for everybody watching this, there's so many questions. What can I do? What can I do? And what I would say is, it's don't think that it's our responsibility to find out what you can do, right? It's your responsibility to think about, why am I doing this? And if what moves you is this deep commitment to lessening the suffering of the poor, then come and apply for a job at Partners in Health or find another organization in which you can do that. But you need to find out what you really are committed to, what you're willing to give your life to, what you're willing to commit to and to persist in, despite so many distractions and people who will tell you that you're not doing the right thing.
Thank you so much. That 75 minutes flew by and it was profound. I wanted to thank the people who submitted questions, wrote their insights and questions in the Q&A box. Thank you for your patience. Apologies for the questions we didn't get to. Taylor, Joanne, Bola, Wanjun, Desi, Mia, Alison, Kaylee, Betty, Alison, Narcissa, Pratibha, Heidi, Andrea, Maureen. I read those names out because it means a lot that you took the time and participated. And I'm so happy that our wonderful panelists were actually looking at the questions. And so don't feel that you were unseen or unheard. Thank you to Partners in Health, of course, especially to Dr. Paul Farmer, Ophelia Dahl, and Dr. Jim Kim for participating in this discussion today. And thank you to the thousands of you watching today. I also want to thank Roku Films and Film Platform for curating so many exceptional documentaries for classroom and campus use. You can see from this example in Bending the Arc the combination of incredible subject matter, fantastic protagonists, deeply important work, and cinema can do, opening up the imagination, the transformations it can capture. It's a time machine. We can meet the young Ophelia and Paul and Jim and follow them through their journey. We can reconjure through cinema people who are now not with us and make them present again. And we can help a general audience understand incredibly complicated things in some way, or very deeply simple, as the panelists have spoken about today. This has been an amazing experience. And finally, I wanted to thank you, ProQuest, for recognizing the role that film has to play in research and discovery. So not only can you access Bending the Arc through your ProQuest database via your school library, you can also get the LibGuide for so much more. You can read Paul Farmer's dissertation, see a curated selection of newspaper articles and journals on the work of Partners in Health, find books on the topic, including Paul's new one coming out, and another short documentary about a Partners in Health hospital in Africa called Open Heart, which was Oscar nominated, a wonderful example of filmmaking too. I think it's about 50 minutes long. It's definitely worth having a look at. So as I go, here's a quick preview of more great documentary films to come on Film Platform with ProQuest. Take a look, and we'd also be thrilled if you would answer a few questions about this event afterwards. It's been amazing being with you all, socially distanced, but emotionally and intellectually very connected. Thank you so much, and good night.
Tabitha.
Yeah.
Can we quickly spend 1 second just saying that those magicians that made this film, that spent all of that time, Corey and Pedro and Keith, you know, they haven't been mentioned tonight, but they were the ones that corralled all of this together and made this film possible. So thank you to them too.
Ophelia, I can't believe that as the head of Sundance Film Festival, I forgot to thank the artists. Thank you so much for doing that. Absolutely. So thank you, everyone, and good night. Have a look at these.
Thanks, Tabitha.
Let me hear you.
If you don't have women, you've lost half the best people.
Whites are becoming a minority in the United States.
I had never seen such misery in my life. I didn't tell that many people about what happened. I'm tired of being a victim.